Hello, everybody. My name is Matt. I'm an 11-year papillary thyroid cancer survivor from Seattle, Washington. And this session is titled Risks of Secondary Malignancy After Thyroid Cancer Treatment. It is my pleasure to introduce Dr. Erik Blomain. Dr. Blomain is a radiation oncologist at Thomas Jefferson University in Philadelphia, Pennsylvania. His focus is on translational cancer research, as well as patient-centered care, advocacy, and survivorship in cancer patients. He completed the MD PhD program and completed his medical internship at Thomas Jefferson University in Philadelphia and his residency at Stanford University in California. And with that, it is my pleasure to introduce Dr. Blomain.
Thank you. I'm happy to present this very meaningful topic to many of us, myself included, because I'm also a 15-year papillary thyroid cancer survivor and RAI recipient. So I'm part of that club. So yeah, I'm happy to talk to you all today about the risks of second cancers after thyroid cancer treatment. And so I think it is useful to define the subject matter that we're talking about today, because we're not talking about a recurrence of your primary thyroid tumor or our primary thyroid tumors, where you get your cancer treated, you're in some kind of remission or cure, but then the bottom scenario on that slide is a recurrence of the primary tumor. But we're talking for these purposes today a second cancer, not thyroid. In this case, I kind of drew it as like a salivary gland, but really anywhere. And so that's the risks that we're going to be talking about today, just to define our terms. I'm going to talk about kind of some thyroid cancer demographics, in that it's a cancer that affects young people. I was actually very surprised to learn it's actually the second most prevalent cancer in young people. And so that's, I'm going to be kind of putting dots on a page in a line to show you why we are in particular as a population of survivors at risk of second cancers. The first dot on the page being that it affects young people. The second is that, which is a good thing, that in general, survival from thyroid cancer is pretty excellent compared to other cancers, and just on kind of an absolute level. You can see kind of these studies of long-term survivorship. You can see, in excess of 90% of people are still alive decades later. So when you combine, on the one hand, that you have a disease that affects young people, and on the other hand, a disease where survival is excellent, so there's many years lived after treatment, you start to see that this problem of second cancers, which is a disease that the incidence of which only increases the number of years you get out from treatment, becomes a problem for our population in particular. So you can see this cumulative incidence curve of second cancers after treatment, which, I think is in some ways a scary figure, because you see that it continues to increase over time and never reaches any kind of plateau. If there is any reassurance to be taken from the graph, it's that I think this is a very important concept for the rest of the talk. The risk of patients that did not get RAI is not zero. So I think when we're getting consented for our treatments and we talk about the risk of second cancers, that obviously sounds very scary. And then patients, I think, tend to think of that as like an all or nothing phenomenon. But we often don't think about that. Unfortunately, the background risk of the general population getting cancer is not zero. It's actually pretty high. So in general, we're going to be talking about these secondary risks as being incremental risks above the background risk, which is already quite high. So again, that's kind of a silver lining in a way. It's also kind of a downer in a way, depending on how you look at it. But in any event, these second cancers being a problem in long-term survivors sets thyroid cancer up in particular for being cancers whose patients are at a risk for second malignancy given our long survival. So I'd like to talk a little bit about what the data is on second cancers, and then what the impact is on survivorship, and then some principles of management, and hopefully things you can maybe take back to your family or your doctor and kind of go from there. So I'll start by summarizing just the main treatments for thyroid cancer. That's not the focus of this talk, but it might be useful. There's the little kind of mannequin figure there with a thyroid tumor. So surgery, I think, is pretty intuitive for most people. You cut out the tumor. There's external beam radiation, which is a form of radiation that I actually give in the clinic, not commonly used in thyroid cancer. There's radioiodine, which many of us have, which is a pill that goes everywhere, concentrates in the thyroid and treats the cancer. And so that's in particular what we're going to be talking mostly about, radioiodine, because that's what most of us get, and that's what generally drives the second cancer risk in our population. So there have been multiple studies that have looked at this. I will just take a moment to say that the studies that have done this are remarkable. It's very difficult to study second cancers because it's a very rare phenomenon, and it takes decades for data to mature. So the fact that we have any data in this space at all is actually quite remarkable. And so if you look at the graphs on the left and the right, the one thing you'll notice is that I think the one that I already showed, which was that graph I kind of used as the proof of concept. But one is it's kind of broken down by types of cancer. One was I think all comers of cancer, and one was I think maybe specifically leukemia and lymphoma. Sorry, I'm not blanking a little bit on the distinction, but the general concept and trend remains the same, which is again that radioiodine increases the risk and that the risk continues to increase over time with no plateau. It's worth noting that this is kind of affected by the fact that the recommendations for RAI use have changed over time, in my opinion, for the better. You can see that these charts, the different colored lines are different sizes of tumors, and which I guess you can use as a surrogate for the risk of those tumors. And you can see that kind of into the 90s, things really increased into the early 2000s. I was treated in 2008, so I was kind of right before the dotted line. And the dotted lines correspond to American Thyroid Association guideline changes that recommended risk adaptation and omitting radioiodine in lower risk patients. So you can see those curves of the use. Again, this is not secondary cancer. This is just the use of radioiodine decreasing after those recommendations went in place. And so, that is kind of part and parcel of what we're talking about, but there was still this hump of risk curve that happened that we're now kind of seeing the decades later kind of effects of. And so that's where a lot of these data that I'm going to present are kind of from that meat of that spike. And so if you look at this is that same study, but a different figure. This is, I kind of boxed off and read the most important parts. You can see that the risk is of RAI second cancers is increased. And so for those of you that know statistics, there's a p-value, which is a statistical inference. And so this is borderline significant, 0.05 or less is usually the cutoff. This is significant. In any event, the risk definitely seems to be a strong trend in the direction of higher risk. And you can see that when you look at age, that even though there are fewer patients in this group, you can see that these numbers are the effect size. So there's for example, a 1.6 higher relative risk of getting the cancers if you were a young person. Again, these are relative to the background risk. So again, not zero versus something, but just relatively. And then if you were kind of in that intermediate age group, a little lower, and then in the older age group, a little lower. And the opposite trend is the number of years out from treatment that we look. If you survive longer and you have more follow-up, you see more cancers. So it kind of this is just data that bears out kind of the intuitive interpretation of the data that I was laying out a couple slides ago. And when you look at it, at the types of cancers, the immune cancers like lymphoma and leukemias, which is what we would call hematopoietic malignancy, those tend to be the most risky in terms of the second cancers that we do see. And then that's been further broken down by solid cancers. So for purposes of these kinds of studies, people say solid cancers as anything that's not a lymphoma or leukemia. Whereas those, they kind of call them more like liquid or lymphoma cancers on the other kind of end of the spectrum. So you can see that so these studies are showing different doses of radioiodine on the right. So the higher the dose, you can see there's some risk increase with dose and again with age. Interestingly, this study seems to show that there was an increased risk in second cancers with age, which kind of goes to show that the data is not always in full agreement on what the individual studies show, but the overall trends appear to be clear. And this study also showed that when you look at solid tumors, it's borderline, it's not really significant. But the total cancers and the liquid cancers are significant. So my interpretation of the data is there's a very slight risk of cancers that are not leukemia and lymphoma, and there's a significant, but still small on an absolute level, risk of lymphoma and leukemia, and that drives a risk in total cancer. It's a little bit complicated, but that's the best interpretation I have of these data. And this is essentially borne out by yet a third study that showed any second cancer showed a significant increase, but when they broke it down by subtype, only leukemia was significant. So it seems as though the risk of leukemia and lymphoma is primarily what's driving the increased risk, not so much the other cancers, but it's impossible to rule out that there's not a small increased risk of those cancers as well. I mentioned that I'm a radiation oncologist and that while I can do radioiodine treatments, most of what I do is external beam radiation treatments. And patients, although rare in thyroid cancer, we do it sometimes. And those patients are also shown to have a graph that looks, in my opinion, very similar to the one that I showed with radioiodine. The breakdown of these secondary cancers would likely be different, although there's no data on that from this paper. Because radiation, as opposed to radioiodine, which goes everywhere around the body, external beam radiation only goes where we aim it, to the neck. So the tumors in that scenario would be in the neck. So yes, it could be a lymphoma of the neck, like the other data, but more likely it could be disease of the soft tissues of the neck or something in that nature. And so to summarize just these last couple slides, I know there's a lot of data in there, that the risk of second cancers increase over time. RAI treatment increases those risks. There's a stronger association with hematologic malignancies like leukemia and lymphoma versus solid tumors, and age and dose appear to be factors in determining the risk for that. So I'm going to pivot to the second point on our itinerary, which is what is the impact of these second cancers? And for this, I'm going to go beyond kind of the obvious medical implications, because these are, can be catastrophic medical events. It's essentially like being back at square one with a cancer diagnosis. I'm going to talk more about the very specific survivorship issues of thyroid cancer patients getting these malignancies. And so I'm going to start by looking at data that shows that even though we have, quote unquote, and this is said mostly ironically, the good cancer, I would never use that terminology and I actually kind of despise it, but we have a cancer that with generally good outcomes, we do not as a population have better quality of life, at least when you look at it compared to other cancers. And if there are some individual domains denoted by like the plus sign, like socially, I guess we do a little bit better, and I'm not quite sure why that would be, but in a lot of things we do worse, which is the stars compared to other cancers. And so it's really remarkable when you think of it, when 90+% of us are thankfully going to live decades, versus a lot of these like gliomas are almost uniformly fatal. And, we still are having quality of life on par with those other cancers. I think that's actually a really remarkable figure. And again, it's a reason that I would point to why this is not the good cancer. When you actually break down what are people fearful of that's driving quality of life decrements, there's a very significant portion are afraid of not just recurrence of the primary cancer, but also a second cancer. There's a quote from the paper that I put in bold down below. And so we have on the one hand these secondary cancers that our population is uniquely at risk for, and then on the other hand we have this significant anxiety that's driving poor outcomes in our quality of life. And so in terms of what that means for management, I think that we need to really do a better job of meeting our survivorship needs and kind of screening for and managing these problems. This is a survey of patients of what needs kind of were not being met in terms of things that could be improved upon. We are fortunate in this room and on this web conference that we've hopefully used this meeting and this organization as a way to find our community and support. But that's not necessarily indicative of the patient population at large, which I think is, I would argue as kind of an aside, that is important to community build and advocate to get kind of patients in a community if they're needing this kind of support. I mean, it's not for everybody, but many people do need it. And then, down the bottom, they're managing emotional, psychological effects from treatment, and that includes these side effects. And again, the scariest side effect, I think, at least for me, is that you could have a second cancer. That's a really scary side effect. So there's a lot of unmet needs that I think providers and physicians need to be attuned to, but also kind of us as advocates and members of the community that have this survivorship experience need to advocate for. And this is just the slide that, again, we've founded this organization, but I think there's really great resources that is offered to meet those needs. In terms of what else can be done, I think making sure that we're very judiciously applying the guidelines and risk adapting where it's appropriate to leave out treatment. More treatment's not always good. And so, I mentioned these American Thyroid Association guidelines that changed in the early to mid 2000s and then changed again about almost 10 years ago. But making sure that we use them judiciously. Typically, that means that if you meet these following criteria, we don't give RAI. And so, I mentioned that in my last talk that I'm on the NCCN guideline committee, which is a little bit different than the ATA, which is thyroid specific, whereas the NCCN is, I'm on the thyroid committee, but that does all cancers. But in any event, they all converge on the same recommendations. The NCCNs are very similar to this. And so if you have a small tumor that's confined to the thyroid that hasn't invaded lymph nodes or the vasculature, and you have good labs and imaging after surgery, generally you don't need radioiodine in those patients. And this is specifically usually talking about papillary or definitely differentiated histologies. Obviously the radiorefractory disease and the other histologies are a little bit of a different story. But using these guidelines appropriately, it's the best way to prevent a second cancer is not give a treatment that causes them. So using these in that way properly can avoid that risk. I think there's also a very interesting discussion to be had about thyrogen. I don't know how many has anyone gotten RAI in the room? Or did you guys get thyrogen? I did too, but I got thyrogen. Okay. So about half got it and multiple of us have had, almost all of us in here got iodine and about half got thyrogen. And I think that's like pretty typical. There's, I got thyrogen in the early 2000s when it was still somewhat experimental, but I think my doctor wisely was like wanting to spare me the effects of hypothyroidism because I was a young college student and trying to do my studies and take the MCAT and all this other stuff that I probably should have put on hold a little bit to recover, but that's kind of a sidebar. But anyway, there's some concern theoretically that thyrogen, one of the downsides is it's artificial. So you juice in the TSH, get a big spike in your TSH, you get a big spike in iodine uptake, which is what they take advantage of when they give you the iodine. And then that falls off very quickly. Whereas when you do it by withdrawal, you get a very slow increase in the TSH that then stays up as the drugs kind of come back on. It's a more biologic, how your body normally functions. It's like slow on, slow off. And some people have argued that oncologically, it kind of spares the tumor when you do the fast on, fast off, because that little tail gives the tumor more iodine. But I would argue actually that, the studies don't really bear out that thyrogen patients do worse, which is why it's approved. But I would argue that lower integral dose to your body and the fast on, fast off is actually a feature, not a bug, because it spares the healthy tissues in that same way potentially, because it facilitates faster clearance of the iodine. And this study showed the red box. And I actually wanted to kind of put a shout out to my endocrinologist, Dr. Ladenson, who's retired, but he was at Hopkins. He's an author on this study. That the dose that was detected in the blood was less in thyrogen patients. So, I would argue that, we're thinking about it in terms of oncologic outcomes and what's the tumor getting, but for these types of issues, I think more about what's the healthy tissue getting. And so it looks like it's possible, though none of this is by any means proven, but it looks as though, if anything, there may be a slightly decreased long-term risk with thyrogen based on just the biology of it and no clinical data. I'm interested in molecular techniques. I'm a physician scientist, so my job is actually 80% research effort and only 20% clinic effort. So one of the things I want to research are what's called liquid biopsies or ctDNA type experiments. This diagram is lung cancer, but it can apply to any cancer. The cancer secretes, as the cells grow quickly and turn over and die, little bits of DNA into the blood that bear the fingerprint, the sequence of the tumor. It's a little trickier in second cancers because you don't necessarily know what you're looking for. Like what if you don't have a fingerprint to look for, to use kind of the legal example, if you don't have a print to match it to, it's hard to do. But I think in the future, if we get really creative, there are ways to maybe use liquid biopsies to do blood screenings for second cancers, though that admittedly is still very much in its infancy. I think, using video visits, this is kind of a slide from my earlier talk that maybe some of you were at about doctor-patient relationships in the digital era, but this is a slide about patient reported preferences about video visits. And you can see that the one of the domains where it's worse is to assess the complications of therapy for cancer. So I love video visits for, well visits and, like your scans look great. You don't have to drive 2 hours to the clinic to see us and park in the city and everything. But I think there's still a place in the long-term survivorship community to just, it doesn't have to necessarily be every visit, but once in a while actually have someone can kind of see you and really give you a thorough once over and make sure we're not missing anything obvious. But I think these are still areas that we need to kind of work on a new normal now that we've gotten all this cool digital health at our fingertips. So my overall message about what to do is, I think the overall take is this is a very serious, potentially catastrophic side effect, but it's extremely rare. You can generally go your whole career and never see one potentially. And again, just that concept that this is incremental risk, not absolute risk that we're talking about, in the sense that somewhere around 1 in 10 there, plus minus a little bit of us in general will get cancer, unfortunately. And the additive risk of that is very small in comparison to that background risk. And so in terms of very meaningfully changes to things and kind of existential stress and anxiety about it that many people feel, including myself at various points, is probably disproportionate to what the actual risk really is, even though it's not zero. And so I'm going to hopefully turn this over to questions and make this more interactive. But I want to just summarize some of these points. The big thing is that, again, the background risk is always almost always higher than the additive risk. I think close follow-up is needed and attention to these secondary cancers. There's no screening in general that we can do other than general health and general screenings like colonoscopies, mammography, that kind of thing. But in the future, I would hope for, and this isn't just unique to thyroid cancer, in patients with any cancer treatment where they're at risk for second cancers, to enable some advanced diagnosis and screening. And just to point on that kind of stress versus real risk thing, that your Ebola test came back negative, but your stress ulcer needs treatment. So sometimes when we're stressing about one thing, it's not as bad as it actually seems. So with that, I want to pause for questions and once again thank you all for your time and for the opportunity to speak at this meeting. And I look forward to answering any questions.
Zoom question. If I had radiation for cancer previously, and then I received REI for thyroid cancer, should I have any more concern about that causing a different cancer down the road?
Thank you for sharing. Yeah, I think, the risk of second cancer, as we've shown from some of the data, is dose dependent. And so even though there are different types of radiation, theoretically, yes, those would be additive risks. However, depending on what tissues your other course of external beam radiation had received, it may or may not play out that way in actuality. Like, for example, when let's say we have a patient that has received RAI in a radiation oncology clinic, we often don't even consider that dose in planning the normal tissue toxicity because it's considered to be negligible. If we were in the neck, then maybe, because again, it does concentrate in the neck, but generally speaking, it's kind of thought to be negligible. Now, that being said, that may just because we don't have a good model of knowing what is at risk. And so we kind of, ignorance is bliss when we ignore it. But I would say, I think each treatment individually has risk and they may be additive, but kind of along these same lines where just very, very incrementally higher and probably on the order of like 1 in 1,000, less than 1%. So again, something to be aware of, but my doctor when Dr. Laydenson retired, I started seeing a doctor at Stanford, and she was really great at being very empathetic and kind of wanting to listen when I needed it. But then sometimes when I was like asking her all these very specific questions, she'd be like, why do you want to know that? You just want to worry about it. Like, I'll answer you, but like, think about why you're actually asking me that. And like, sometimes getting a kind of rewiring on it can really be, I think, helpful, because again, the absolute risk is very, very low.
Do we have any data on the risk for patients that have taken up more than 200 millicuries, 400 millicuries, 500 millicuries?
Yeah, let me see if I can scroll back. I kind of glossed over the data because I thought it was a little too busy to really get into the nitty gritty of it, but one of the figures has that on the right hand side. That the blue line is it says 201. I think that's over 200 and over is what I think that actually is. So there is an added risk. Again, if you look at what the axis is, that's like 0.05, 0.1. So it's not, again, not zero, but that's the cumulative, that's the absolute like cumulative risk of it happening. So that this kind of normalizes out the background risk as best I can kind of explain it. So, we're talking about very, very minute differences, but yes, it does appear that the more dose, the more risk.
Hi, Dr. Blomain. It's me again.
Hi.
Hi. I have a question around what kind of cancers, like does the study share what kind of cancers are like the most prevalent for secondary cancer?
Yes. And so, again, most likely it's leukemia and lymphoma. Those are the highest risks. So this graph on the right showed all the different kinds of cancer, but the only one that was significant was all cancers. So when they look at it as an umbrella term, and leukemia individually. But when they looked at, like, you can see the rest of the list, when they looked at bladder individually, it wasn't an increased risk. When they looked at breast, it wasn't an increased risk. I will say the trend of those all in multiple studies seems to be slightly increased, but the biggest risk seems to be increased in things like leukemia and lymphoma. And that seems to be driving the overall trend towards more cancers. But like this other study I showed somewhere, where's that? Here, like these are the solid cancers, so not leukemia and lymphoma. This the stats are a little complicated, but basically this is pretty close to 1. So if this was over 1, it might be significant. So these are pretty close. So there's a trend of more solid cancers, so to speak, but not necessarily significant in every study. But multiple studies have borne out the risks of leukemia and lymphoma. So I think the best overall synthesis of the data is that there's an increased risk in all cancers, primarily driven by leukemia and lymphoma, but there might be a minor contribution of other cancers as well. And those kind of run the whole gamut of the body and different tissues, because the iodine kind of goes everywhere to some extent.
If you get a second cancer, is the genetic profile of the second cancer the same as or similar to the thyroid cancer?
That's a great question. I think in a lot of ways that hasn't really been studied, because again, this is a rare event. And so that makes it like very difficult to study. In general, we would not necessarily expect that the genetics would be similar. We would expect that this was a new cell that was damaged by the radiation, like de novo, not something that had come from the previous cancer. Though we don't know for sure.
This may be outside your study, but I'm going to ask in case you know. So for someone who did not get RAI, I've always heard of the relationship between thyroid and breast recurrence, and they're underage for a 40-year-old mammography screening. Is it recommended generally that they begin mammography at an earlier age, 35, for instance?
In terms of patients that did not get RAI, I'm not aware of any increased risk in breast cancer, though there very well could be. I'm not aware of it though, personally. And generally, I think the screening recommendations are the same as the general public. Whether they should be, I think that would need more study. But I think generally there are no special screening recommendations for thyroid cancer survivors, and most oftenly not in survivors really. Period. Generally speaking, the screening recommendations remain the same. Again, should they? I think that's a different story. But yeah.
Could you explain further the differences between external beam radiation and RAI?
Yes. So RAI is a pill. You take it orally. It goes throughout your whole body, but your tissues that concentrate iodine, so namely the thyroid for purposes of our medicine here, but that helps the radiation fight the tumor. The side effects are driven by the fact that some other healthy tissues uptake iodine as well. But at the end of the day, it's a pill that has a single isotope of radiation that, like if you took an iodine, like iodized salt or something is used because the thyroid, it prevents goiter because the thyroid, metabolizes iodine. We leverage that biology to specifically kill thyroid cancer, as opposed to external beam radiation, which is given from a machine, a linear accelerator. It's similar to like a CT or an X-ray machine in that it makes X-rays, and it's not invasive. The beams are like any other X-ray. It kind of passes through the patient. They're not radioactive. There's no precautions, but it only goes where we aim it. It doesn't go throughout the body. So in a thyroid cancer patient getting external beam radiation, they would likely be getting it to the neck or some area where the cancer has recurred. And those of us that got an RAI know that because we take a pill and it's in our body and it stays there for a while, we are radioactive and actually have to take precautions for a week or two. So external beam does not share that particular risk or requirement.
A request, not a question, but could you show the slide with the parameters for doing RAI treatment?
Sure. And these are actually parameters to not do treatment to most correctly, but yes, I think I take your meaning. And yeah, so generally these are reasons that we might omit RAI. These are kind of similar to the lower risk patients in which we might even consider only doing a hemithyroidectomy. That's kind of outside the scope of this talk, but yeah, generally there's a lot of risk adaptation going on in early stage thyroid cancer these days towards de-escalating treatment.
I have two questions, but the first question is for when would it be a case for a person to get the external beam radiation versus the RAI? That's the first question. And then I'll wait for the second one.
Okay. In thyroid cancer. So by the way, this is an area that I'm interested in actively like building out and kind of doing more research in this space to try to see, because my mentors and people that trained me that treated thyroid cancer, they had said a lot of times we don't see the patients until their recurrences have gotten fairly extensive. And then just like surgery, it does get harder and harder to treat kind of the more that we do. So, but I'm kind of sidestepping the question. Generally speaking, we see recurrent patients when the surgeon tells us that this repeat surgery would be very challenging. And so we want to go for it right now to maximize the chance of controlling the tumor in that area, because radiation is local treatment. Again, the external beam, it only goes where we aim it. And so when we want to give it the surgery some extra like for some extra push to get rid of any microscopic cells that are left behind after a surgery, to prevent it from coming back in that area, it's unlikely to increase survival. Then again, very little of what we kind of do once in the recurrent setting really has a good survival data. It's usually we're kind of just doing our best guess at how to treat. But yeah, so generally speaking, though, it would be a recurrence when repeat surgery would be challenging. We would typically offer it then. I would argue that it should maybe happen earlier in the natural history of the disease. If there's someone at higher risk, that maybe we consider intervening earlier with that kind of treatment, but that's a little bit more of a controversial recommendation. Whereas radioiodine, on the other hand, is given very commonly. There are, obviously guidelines to not giving it, but generally speaking, it's considered a lower toxicity kind of standard treatment for thyroid cancer. And it's pretty commonly given after surgery for most, I would say most patients with differentiated do end up getting it.
Okay, not my second question, but just as a part B to the first question.
Sure.
Is the beam treatment, like let's say people that have breast cancer, that they have a radiation where they have to go every day for like a month? Is it similar to that, or? Yes.
Yeah, it would be every business day for probably something about 5 or 6 weeks thereabouts. There are other forms of radiation where we might treat just one little, let's say someone, God forbid, has like a little lung metastasis. We might treat that in like a single shot with a very high dose just to obliterate it in that one area. But if we're talking about treating kind of a whole surgical field, a large area, which these patients typically present with, then it has to be slower and lower dose. So it's kind of like your body can tolerate it when it's cut into more pieces, because it's like kind of taking it more slowly. Whereas if it's just a tumor in a tiny area we're treating, we can go really fast. So but generally speaking, yes, it would be like the experience people might have with like people that had breast cancer. We're treating deeper in the body, so the skin effect wouldn't probably be as severe, like, because I think most people think of like sunburns and things like that with patients that get breast cancer radiation. But the downside is when you treat the neck, sometimes you get the internal structures. So kind of the throat and the back of the mouth and things like that. And we can cause some pain there. So it's not a treatment we offer lightly, but I think it does control the tumor well in that area when we do offer it. So I think we just have to be very careful with who we select it for. But I think in the recurrent setting, I think we should be a little more liberal in how we use it overall.
Now my second question, sorry.
That's okay.
So for a person that has done radioactive treatment twice and found out that they have BRAF, right? So, and the treatments didn't work. How could I say this? Like, personally, like, I'm scared of getting a second cancer, but I feel like there's radiation and everything, right? Like when you go do x-rays or certain tests to check for stuff, like, is that something that we should be like try to limit those type of test scans, or those test scans really are not going to affect, like in combination with our RAI, it's not going to affect us from getting a second cancer?
Yeah, there's no like safe threshold where, you'd say that it's not increasing the risk. Like every scan, everything increases it very, very slightly. Just personally speaking, and whether this is based on nothing except my own like fear, probably I've declined dental x-rays just because sometimes, I don't know, I'm kind of that difficult dental patient, I guess. But kind of along the lines of what you're thinking, there's not great data on how they interplay. This is an aside, but there's actually some thought now. So when we give radiation for breast cancer or for thyroid cancer, we do a lot of imaging studies on the radiation machines to make sure that we're hitting the target. And some people have actually modeled out that those scans every day are like giving a significant amount of extra dose beyond what we think we're giving. And so people have like now started to hypothesize that might be giving more radiation than we want to. So I think there's lots of like hypotheses, but I don't think there's great data on any of it. But in general, I mean, I think that generally if a test is being ordered, the risk benefits probably justify doing it. Most people don't order tests kind of on a whim. And so I think with an established diagnosis of cancer, generally, scans are probably the risk of the second cancer is probably outweighed by the benefit of the information that the scans give. And so I wouldn't necessarily, as a blanket statement, avoid scans, but it's okay to think about it and be judicious. And if, you're getting radiation that doesn't involve the cancer, like a dental x-ray in my case, like ask, well, why are we really doing this? Like, that's totally fine. But when it's like kind of an oncologic scan or something for your general health that's putting you at risk, I would not decline scans.
So, I am really interested in this topic. So 2 questions. Does the study show or have any participants that were RAI resistant, so received RAI, but also received external beam radiation?
No, I'm sure that the population of people that had the external beam in the figure, because it's thyroid cancer, I bet a lot of them did have RAI, but I don't think I don't think they broke it down that way. And I don't think that's been looked at. And I mentioned that when we're seeing those patients in a radiation oncology clinic, we generally don't consider the dose that they got with the RAI. And I've always been a little bit uncomfortable with that. I think partially it's just because it's very difficult for us to actually say, what does that mean? Whereas, when let's say I saw a patient that had treatment to their breast and now I was treating their thyroid, I from all external beam, I would create what we call like a plan sum of all the radiation from both plans before I gave it and just make sure there wasn't overlap and there wasn't like an unsafe dose achieved. But we don't typically do that with RAI, and I think it's because we just don't have a good way to model what it does in the body. But I still think overall the additive risk is pretty low, because I think the systemic dose of the iodine is very low. But it is theoretically more like best practice would probably be to theoretically do it, but it's just not something we routinely do. And I think because we just kind of assume it's negligible and that we can't model it very well.
Okay, perfect. Thank you. One more question. I know you got to go back to the Zoom room. My other question is around, so I have actually been one of the people who's had secondary cancers to my appendix, potentially in my liver, in my uterus. And so I guess my question is, how do you know if the REI or the external beam are like the causes of it?
Yeah.
I know you can't, but like,
yeah, it's very difficult. I mean,
Yeah.
there's no slam dunk to know. And then that kind of dives into this other realm of like, are there undiagnosed like genetic syndromes that we don't know about, or some other reason why people get multiple cancers? So other than kind of being able to make a statement of at the population level, there's not really a great way to say, oh, this cancer in particular was radiation induced. That's actually an area I'm interested in researching. Are radiation induced cancers like different biologically in some way? But we don't know the answer to that.
Can we use MRI instead of X-rays or CT scans? Would that reduce the avoid the exposure to radiation?
In general, yes. And ultrasound also, by the way, which is a mainstay of screening for patients with thyroid cancer, also kind of sidesteps the radiation. It's like pick your poison. MRI, I definitely favor MRI in a lot of ways, but people have said the contrast is not great either over time. There's some studies now that the gadolinium they use is not cleared very well by different tissues and might not be the best thing either. But it is not radioactive. So, right, it wouldn't have these particular risks that we're talking about. But other than ultrasound, which is sound waves and generally pretty safe, I don't think there's like a free lunch with imaging, really.
You have any idea what the whole body exposure in millisieverts might be if someone received 332 milligray per centimeter in a PET CT?
Taking me back to my physics boards, I honestly would have to sit down with that math and do that. I'm sorry, I don't have that off the top of my head.
Question about whether or not a genetic mutation would influence the recommendations listed here. Like, would a BRAF sway this recommendation that's on the screen? And then also, I know that BRAF is like a driver of other types of cancers as well. If I have a BRAF mutation, does it increase the likelihood that a BRAF in another type of cell would go haywire too?
Yeah, I've always been fascinated by that. I don't think that's been well studied, but yeah, melanoma is a notable one that's also like very heavily BRAF driven. I guess there was two questions. I think high risk histologies would change this, but I don't think the recommendations to omit actually really take BRAF into account. I think 60% thereabouts, 2/3 or so patients have it. So I think if you were to make, say we have to give RAI in all BRAF patients, you'd essentially be saying almost all patients have to get RAI. So I think these risk assessments are independent of that. But then again, if it has high risk histologic features, these variants and things of that nature, that would affect it. I'm very along those same lines of like the radiation tumors having different biology. I'm very interested in these kind of combined susceptibility type questions. Like, are there different regions of the genome that are like prone to like mutations in certain people? But I don't think we know that answer yet. But that's a great thought, something that I've thought about a lot, and I just don't know that we have the answer to that yet.
Are liquid biopsies an option for secondary cancers?
Not currently clinically. They are emerging in the setting of if you have a tumor that we know what it like looks like, we'll say like genetically, that you could then look for it. So imagine you get surgery, you get radioiodine in this case. It's more commonly used in lung cancer though. Like you get a lung surgery or you get chemoradiation. And then at the end of your treatment, if everything worked according to plan, you wouldn't see that fingerprint in the blood anymore from that tumor. But if you saw it, you might be nervous that your treatment didn't have the effect that you had hoped. And sure enough, that seems to be true. Like those things that you can risk adapt, give more treatment if you detect it, possibly scale back treatment if you don't detect it. But that's kind of with the pre-information that knew the tumor that you were looking for when you started. The challenge becomes because liquid biopsies are great if you know what you're looking for, but it's kind of like trying to find a needle in a haystack because the vast majority of the DNA in your blood is your own normal DNA. And so if you know what you're looking for, you can purify out what you're looking for and kind of get rid of all that background. But if you don't, and in the case of secondary cancers, we necessarily wouldn't know exactly what we were looking for. It becomes very challenging. I said, I'm not ruling out this is, my lab is actually one of our focuses on liquid biopsy. So I'm not ruling out creative approaches to doing this kind of thing, but it's not in prime time yet. And it's just entering its prime time for any application of any kind. So I think we're in a growth area with it that I'm really excited about, but yeah, nothing like that for second cancers yet.
This might be out of your realm of expertise, but if I had a friend that just had radiation treatment for thyroid cancer, do you have any suggestions on the best way to support them?
I'm going to assume they had radioiodine, I guess, it's not totally clear from the question, but I think that's very individualized. I think for me, that was, I think at the point I was at the lowest of my treatment during that isolation period. So I'm hoping your friend is kind of through that isolation period if they did get RAI. And it kind of, because I don't know, during the isolation, you very much feel like literally like toxic to other people. Like, you feel like you can't go near them. You feel like it's a very keen reminder that you're different and you're actually dangerous to other people for a time. And so not the stigma, but the after effects of that remained with me for a little bit. So I would say every person being different, sure, but speaking in generalities, just maybe making an effort to include that person and let them know that you don't think of them as different might be a good place to start.
Is there a blood test that I could take to reveal any other cancers that might show up in my genetic makeup?
That kind of goes along the lines of the liquid biopsy question. And, there are some companies, I think, with varying amounts of kind of questionable data that'll give you like cancer risk screens. I don't have a lot of direct knowledge about those. I am very skeptical of them in general, the cancer susceptibility screens. I know they're very popular because it kind of helps people feel like they're empowered to kind of be involved in their own care, but I don't think there's great data for that. And then in terms of the actual like liquid biopsy type approaches, I already kind of mentioned that we're not there yet. So other than kind of the typical screening paradigms for colon cancer, breast cancer, things like that, there's not a magic bullet for screening.
If I received I-123 twice, 20 years ago, and also lived 500 miles in the wind pattern from Chernobyl, is there any association of follicular and Hürthle cell carcinoma from the radiation?
The I-123 is generally not thought to be too much in terms of like biologically effective to cause DNA damage. It's really more of a screening, like both the doses used and the characteristics of the isotopes. The Chernobyl thing is a little more complicated. I think anyone that was close to that area, I think, has some increased risk, and of those increased risks, thyroid cancer would be a very likely candidate. So I would say no to the first part, but yes to the second part. But it's hard to quantify exactly what that might be.
I think this will probably be the last question for the session. Do you know of any options for a patient with papillary thyroid cancer that is looking to get a genetic analysis?
Depending on where you're treated, it may vary by institution, but most institutions do have a molecular panel that they'll do they may or may not do it upfront for all patients with papillary because the good news is we usually don't need it. But in the term, and when I say needed, I mean in the sense of using, let's say, one of the new drugs for BRAF mutations or RET fusions, or all these targeted therapies for these new molecular events. They may not routinely do it, and payers may or may not pay for it for a cancer where we may or may not need it. That being said, if in the longer term the cancer were to recur, generally that material is available either from a rebiopsy or from the prior biopsy, and we can sometimes kind of work backwards to get there. But yes, it is possible to do and is done clinically in many places. It's just kind of a matter of in the specific case, like does the institution and the payer kind of allow for it? Because it's one thing to have a test for knowledge, which is great, but if it's not going to change what we're going to do, which is in the case of a person, we're going to do surgery most likely, and then we're going to risk assess based on what we see on surgery to give RAI or not. There's based on one of the questions before, really not much of a role to like molecularly risk adapt for BRAF, let's say, or something else on that basis. So I'm all for more information, but payers get funny sometimes if it's not like going to influence our clinical judgment. And sometimes too much information is actually not a good thing in that way.
Any other questions in the audience? Okay. Thank you, Dr. Blomain, for your time and willingness to be open with the questions. And thank you for all the questions in the audience. This is the final session of the conference. So thank you for all attending online and in person.
Yay. Yeah, thanks.
And we hope to see you all next year. Thank you.
Thank you, everybody. It was a pleasure.